All right, hello. Hey, welcome to Sanibel 2022. Nice job. I'm going to clap in advance. Just that was a little bit of applause for the organizers that put this together. Really shaping up to be a nice meeting. 4 days of content. Pretty impressive, guys, so thank you for that. My name is Jeff Light. Hello, welcome again. So this next session, this next Sanibel Kickoff Luncheon, is brought to you by the company I work for. It's HemoSonics, LLC. Briefly, we are a company out of Durham, North Carolina, with our flagship technology that was born from the University of Virginia. Currently, we are singly focused in the realm of critical bleeding related to coagulopathy assessment and optimization in order to support a truly comprehensive and patient-centered blood conservation and management program. I am now pleased to present to you Dr. Pierre Tibi. Dr. Tibi is the Chief of Cardiac Surgery at Yavapai Regional Medical Center in Prescott, Arizona. He is also there the Director of Patient Blood Management, past President of the Society for the Advancement of Patient Blood Management, aka SABM. If you're not familiar, please check out SABM. And is principal author on the recent 2021 Clinical Practice Guidelines published jointly by the STS, SCA, AmSECT, and SABM. Dr. Tibi is going to come present his journey in patient blood management, discuss various best practices and their supportive data, and offer some specific cases in coagulopathy management generated throughout. So, no further ado, Dr. Tibi. Thank you.
Thank you very much, Jeff. It's a pleasure to be addressing this august group, and I've been asked to talk to you a little bit about my personal journey with patient blood management and how only recently that I have incorporated viscoelastic testing. So many things, these are my disclosures. I obviously present for HemoSonics and Baxter. So many things change. This is me in 1990, and I want to draw your attention to the cool boots, the white intern pants, the digital watch, the paper records, the cool hairdo, and the tab. And the only reason I put this up is that things change. Back then, cardiac surgery was done, and giving blood was simply an expected treatment during cardiac surgery. So when I started in practice in Phoenix, Arizona, I got approached by a gentleman who told me he was a Jehovah's Witness. I wasn't really quite sure what that was, but that he would not take blood. And he would not take blood under any circumstances. And he had been to several cardiac surgeons in town, and they all said, well, if you don't take blood, I'm not going to operate on you. You know how cardiac surgeons are. So I thought, well, other surgeons don't, why should I? And then I started thinking that, well, you know, these poor patients have nowhere else to turn. And then, hey, this is a challenge. How can I safely do this? So I started thinking a little bit and came up with, can I risk operating without the safety net of blood, which at the time, 75% of patients undergoing cardiac surgery required blood. And I figured that if I just use common sense, meaning if I just have adequate blood stores, if I don't lose blood and maybe tolerate some anemia, maybe I can get this guy through. And by the way, I was new in practice and I needed the work. So I decided to do this. And all of a sudden, I got a lot of patients from, this was at St. Luke's Hospital in Phoenix, and I got a lot of patients that came specifically to this hospital. Even though it was a smaller hospital, we operated at several hospitals throughout Phoenix, but this was a smaller hospital, and word had gotten out that there's this guy in town that's stupid enough to operate on patients without needing to give blood. So actually got about 100 patients at Jehovah's Witnesses, and I had this thinking back in 1995 that, or not shortly thereafter, with all these patients, I kind of started thinking that I think my no blood patients are doing better than my blood patients. And at the very same time, there were more and more publications that were coming out talking about this blood conservation in cardiac patients. When I looked at my evaluation and looked at my patients specifically, I did in fact see that for some reason my patients that I was not giving blood, which was the life-saving blood that could get patients through for cardiac surgery, when I was not giving the blood, that these patients were actually doing better. This is one of the other hospitals. This was the main hospital that I operated back on. And in about 2005, I became chief of cardiac surgery there and would bring patient blood management there. At the time, we called it blood conservation. And what we had done, not only using techniques like tolerating anemia and so forth, but I started to implement all these things that were coming out at the time that would decrease the risk for blood transfusion during cardiac surgery, and that's preoperative, intraoperative, and postoperative. It included things like ANH, retrograde autologous priming, antifibrinolytics, use of topical hemostatics, pretty much everything that I could think of, putting together a multimodality therapy to treat patients. And we were able to, and trying to encourage other cardiac surgeons. There were about 8 cardiac surgeons at this institution, of which 4 of them were in my group. And we started to do that. And just in the first year that we initiated this, we had come down, and this was for all the surgeons, we had come down to about half in just 1 year of the amount of blood that we were utilizing. So in 2007, I was recruited to start an open heart program from scratch at a hospital called Yavapai Regional Medical Center, which is up in Prescott, Arizona. It's the most beautiful part of Arizona. It's up about 6,000 feet. It's temperate, and I would encourage you guys, if you ever get a chance to go there, to go. It's really, really gorgeous. Anyway, so that's one of the reasons I went. And before I got there, the hospital was worried because YRMC was going to, having a heart program there was going to severely stress the blood resources there. So what they did before I even got there is that they increased the staff, they increased how much blood and blood products they would keep on hold. They bought refrigerators and increased their lab capability. And the first 6 months, I started in June, and the first 6 months I used 40 units of blood for approximately 45 patients. So this was the cost of blood at the hospital before, or in 2010, 3 years after I got there. And you can see that the hospitalist used most of the blood, followed by oncology, ED, family practice. And in cardiac and thoracic surgery, we used 40 units for that entire year at a cost of $48,000. The entire cost of blood there was $2.5 million. So now things came on, and let me preface this. When I was at Good Sam, and you saw in that multimodality slide, I didn't have viscoelastic testing. We actually did have the early types of machines, and we found that they weren't all that accurate, and this was back in, like I said, in the early 2000s. They weren't all that accurate. They were very sensitive to vibrations. Oftentimes the machine would say, it would give me this complicated graph, and it would say that my patient is bleeding and needed all kinds of things when actually the patient was bone dry, or vice versa. And I think that was in the development of viscoelastic testing. So when I started the program at Yavapai Regional Medical Center, because I didn't think that it would significantly increase their amount of blood conservation, I did not feel that that viscoelastic testing would be useful in the new program. And when you back around 2008, this is a report by Art Bracey that showed that blood transfusions during cardiac surgery was a very highly varied practice. There were some programs that were transfusing only 9% of patients undergoing for primary CABG, whereas some programs are transfusing 100%, everybody, and similar differences in the amount of transfusions for platelets and FFP. And recently, last year, the World Health Organization came out that there is an urgent need to implement patient blood management in all types of medical care. And in last month, last month, Arya Shander published this global definition of patient blood management, which says patient blood management is a patient-centered, systemic, evidence-based approach to improve patient outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. Please note, it does not talk about transfusions anywhere in that at least summary statement. Because when we have kidney failure, we don't treat right away with a kidney transplant. When we have heart failure, we don't treat right away with a heart failure. When we have blood failure, meaning not enough blood or the blood is not working as well as it should, it's not coagulopathic, blood transfusion shouldn't be your first and foremost knee-jerk reaction. So this was my patient blood management package, which is a complete care package at Yavapai Regional Medical Center when I started. And it requires preoperative evaluation of the patient, treatment for anemia, many intraoperative techniques that we utilize and that you all utilize, as well as postoperative point-of-care testing, postoperative not tolerating bleeding. But like I said, I didn't have viscoelastic testing. And 3 years ago, once I started really looking at the literature, I had seen that viscoelastic testing had improved significantly from the time that I was using it back in the early 2000s. Many of the problems with viscoelastic testing were worked out, and it was way more accurate, and the literature showed that. In fact, with a bunch of people from this organization as well as others, I was very thrilled to be part of the 2021 STS, SCA, and now AmSECT and SABM update to clinical practice guidelines. And the old guidelines were on blood conservation, and now we're called the Guidelines of Patient Blood Management. And in being part of this, once again, I realized that one of the most important changes to the guidelines is that now goal-directed transfusion algorithms, which incorporate point-of-care testing, such as with viscoelastic devices, is now a Class 1 recommendation for cardiac surgery. So, like I said, this was published last year, but I started looking at it about 3 years ago, and I wanted to reinstate viscoelastic testing as part of my patient blood management care package for my patients. And when I started thinking about it, well, you know, some of the things that I had experienced with viscoelastic testing in the past, I wanted it to obviously be accurate because it was a considerable expenditure for our program. The interpretation needed to be relatively easy, that the quicker you can get the results, the better, because you can treat active bleeding. It needed to be a simple process, needed to have good technical support, and easy adoption of the process. Because when you have a bleeding patient, now before viscoelastic testing, as many places, I would say probably less than half of the open heart programs, believe it or not, utilize viscoelastic testing currently. And when you have bleeding, bleeding begets bleeding. You really need an answer real quick. With the plasmagenic tests that I was using, like PT, PTT, and platelet count, you know, not only would we have significant bleeding to get that, but then we send the test to the lab. It takes a while to get, and then when you decide what you're going to give, if you have an idea of what you need to give, You're talking about an hour and a half to 2 hours of treating aggressive bleeding, which now the scenario may be completely changed. Your coagulopathic dysfunction might be different at this point as opposed to when you were first started seeing the bleeding. Whereas if you have a rapid test that gives you an idea of what's going on from a coagulopathic situation within 15 minutes, then you can give fibrinogen, which is pretty much right off the shelf so you're treating within 30 minutes, or even if you wait for cryoprecipitate, you're treating the situation much more rapidly. So that is what you needed to do. So after 13 years without viscoelastic testing, even though we were transfusing less than 10% of all open heart patients, and mind you, this is not just primary CABG, this is redo valves, redo, dissections, etc. We were transfusing less than 10% year after year after year. Would viscoelastic testing, would the expenditure of a device for viscoelastic testing be warranted? Because that's what my finance people say. Well, what's the ROI? What's the return on investment? So we decided to have a trial just to look at the various different machines out there. And these are the 3 viscoelastic testing analyzers that are on the market today. And at this point, I'm going to give it over to Julie or Jeff to talk to you about the Quantra system.
Thanks, Dr. Tibi. Okay, so I'm going to give a brief introduction here to Julie Navarro, RN, MSN. She is the clinical science liaison at HemoSonics. She is a pediatric nurse, has experience in the care of acute COVID patients, and is SABM certified and trained previously as a patient blood management consultant with one of the top consulting firms, Acumen. I'll give it away to you, Julie.
All right. Okay. Like you said, I'm Julie Navarro, so I'm the clinical science liaison at HemoSonics. I've spent a lot of time in my career in patient blood management, and I will say early on, I was at Johns Hopkins All Children's and was given the task of starting a patient blood management program when nobody really knew what that term was, except for perfusionist. Close. Okay. I've never been told I'm not loud enough. That's a new one. Okay, is that better? Okay, thank you. So I used to reach out to the perfusionist a lot at All Children's to explain, outside of what I knew, which was bone marrow transplant at the time, how people were treating the bleeding patients, and there was a lot of techniques. But I will say that you guys have always been early adopters of patient blood management, so I appreciate that you guys have helped us move our practice forward in what we're doing and trying to change outcomes. So before Dr. Tibi goes on to explain the Quantra in the use of his cardiac cases and the difference that he's been able to make, I kind of want to level set here just for those who have never seen the Quantra and give a very high-level description of its operation and its interpretation. And I guarantee you in the next 5 minutes, I can sign you guys all off on the competency because you'll be competent. All right, so as far as it's meant to be a very quick, intuitive flow, quick, intuitive flow. I think I filmed a perfusionist from Mount Sinai last year. It might have been for Sanibel, and it was 24 seconds of hands-on to get the test started. So you draw your specimen. It's 2.7 mLs, which most of them just do 3 mLs draw. It goes into your normal citrated blue top for your coags. You are going to scan the cartridge, which is kept at room temperature in the OR with you, and then we got to move forward. I got to stay coordinated here. There's only one spot, if you come over to the vendor area, there's only one spot the cartridge can go. No confusion here. There's no waiting to get it to room temperature or anything like that. Simply, you're going to scan the cartridge, scan your user ID, scan the patient. The screen is going to tell you each step along the way in case you forget everything I told you when I was training you at the hospital. Couple of inversions of the tube just to make sure you get that citrate mixed in with the sample. Upside down, push start. So I think last year, Mark Piso said 1, 2, 3, or VT easy as 1, 2, 3. And that's pretty much how it goes. So no mixing, No, like I said, waiting, no calibrating or anything like that. It's just draw the sample, scan all your IDs, and push start. And these are our infamous dials. So this is the result screen that you will see. What I tell everybody here is if you can drive a car, then you can read a Quantra. Do you have enough gas? Are you going too fast? You see and it's meant to be intuitive. We have some color pop here. Even if you haven't memorized the reference ranges, and I know early on in my career as a nurse, I didn't necessarily know all the reference ranges for all the labs that I was drawing, but you can see that it's color-coded, so green is good. You have your reference range in the green area. Your triangle is where your patient currently is, and if it's outside of that reference range, you see that it'll turn color, so you have a yellow. That kind of brings your eye to that it's out of the reference range. That this particular patient is being carried by some anticoagulant there. We'll go over what each one of these means here in a second. It's, once again, touchscreen, but you have options here on the left, and we'll go over that in a second here, too. There's the dial screen. If you really just like your curves and watch how a clot is formed, we do have a curve screen, and then there's a trend screen. So you have options there. And what else do we have on the screen? The printer. No. All right, so let's start with the top row, sorry. So this top row is clot time. So we also wanted the parameters to kind of match what they are and be very easy. Clot time with heparinase is your CTH, your clot time, CT, and the ratio of the two. So I think some other platforms you have to look at the tracings and compare the two tracings. Basically, Quantra does it for you. And the ratio is the CT over the CTH, if you do the math there. And if your clot time, the one that's affected by heparin, is carrying it, you're going to get a larger CTR. So 1.4 is our one trigger that we validated that would say your patient is still being influenced by heparin. So basically, this is the time it takes for how quickly or how slow is my patient able to generate thrombin to form a clot. Oh, I should have put the parameters up there. There we go. So once again, the first one's clot time with heparinase, so neutralizing the heparin, your clot time, and then your clot time ratio. Things that you're going to see here, by the way, these results come back and are resulted on your screen in about 3 to 5 minutes, so it's very quick. You can see that if you were on pump or if you were post-protamine here, you could see the effects, one, of heparin, so I'm going to prioritize, do I need a product or do I just need another dose of protamine? You could see hemodilution if you were on pump. You could see hypothermia, as you would probably see a prolonged clot time. You could see if there's any sort of factor deficiency in the patient with that CTH. So the bottom line, the total test time is 15 minutes. So the bottom, basically, how strong is my clot? Do I have a strong clot? Do I have a mushy clot? So once again, we try to make the parameters named after what they mean. So clot stiffness. Clot stiffness is made from two things. P for platelets, F for fibrinogen. So the platelet contribution to the stiffness, the fibrinogen contribution to the stiffness, once again, mathematically, if you add the PCS and the FCS, that's your total clot strength. So this one is the stability of the clot. If I had a weak clot, if I had a low CS, I'm going to look at, well, is it the platelets or is it the fibrinogen? Do I need cryo or do I need platelets, basically? Once again, I went faster than I put the names up there. And this is really where you start to look at, once again, prioritizing and kind of targeting your therapy, where historically, we had that shotgun method of they were bleeding and they give a round of everything. Now I can tell by the top row and the bottom row, do I have a factor deficiency, do I have a platelet deficiency, or a cryo, or just a dose of protamine. The other screens that I talked about here is your curve screen. If you're just used to those, you're very proficient in reading them, you can watch as the clot is forming and watch the dynamics of that clot. And then your trend screen. So I see a lot of people use this in the communication with their surgeon. They may ask, what is my Quantra as you're on pump? And so they use it as, well, where was your baseline? So, hey, we're still in normal range, but we've lost half of our platelet contribution. So it starts to become a communication tool more than anything else when the perfusionists are running it and kind of giving the results back to either the surgeon or the anesthesiologist. And everybody kind of, between the anesthesiologist, the surgeon, and the perfusionist, they're kind of all on the same page because they can see, as throughout the case, where this patient started. A lot of cardiac cases we see start off hypercoagulable as they are in that inflammatory state, and they may have lost their, all of their fibrinogen contribution, and you can kind of see it on that trend line there. You guys are all competent and signed off. Any questions? Okay. I'll hand it back to Dr. Tibi. I used it.
Thank you very much, Julie. So let me pick up where I left off. After 13 years without viscoelastic testing, I was convinced that viscoelastic testing had come to a point where it should be part of a program that is focused on patient blood management. And like I said, we tried all 3 devices. We had them brought in, tried them for a couple of weeks, and they all worked very well, had some differences among the different devices, but I was really most impressed with the Quantra device. This was the very first case where I had the Quantra device in my operating room. So this was a redo AVR MVR that obviously needed surgery, and this is the Quantra that was pre-incision. So the platelet count was 137, and the PDT was 13.4 and 26.6, and that's really all I would have had to go by pre-operatively. So before we made the incision, the clotting time was good, and the clot stiffness we could see already was somewhat hypocoagulable, and we can see that it's mostly due to the platelet contribution for the clot stiffness. At this point, before I even made the incision, I said, hey, maybe we'll get a unit of platelets to give to this patient when we correct his coagulopathy, meaning after we've reversed the heparin with a protamine, and we've given our ANH. I do ANH on almost everybody. During surgery, while we're on bypass, you can see that there's no clot detected, obviously, since we're on bypass, and that's a good thing. But once again, our clot strength is even lower, and once again, it's mainly due to the platelet contribution to clot stiffness. And then after surgery, we're still in the operating room, so this is at 11:30 or so. I've given my protamine. I've given my 2 units of ANH, and I've given that 1 unit of platelets that I had right on hand so that I can give it as soon as we come off pump, so that I'm not there wondering, hey, why is this patient oozy? And I watch the chest tubes. And we get a repeat Quantra, and our clot strength is still low. And once again, our fibrinogen is relatively normal, maybe low normal, but our platelet contribution to clot stiffness is still low. So I said, well, let's get 2 more units of platelets in the room, and let's go ahead and give 1. So I'm in the operating room. I've got the chest closed, but I see that the chest tube drainage is not increasing now. It's slowed down, whereas before it was 150. You can tell that it was actively bleeding. And I get another Quantra, and here we are. We're all green. We're all good. It's 12:23. Let's take the patient to the ICU. Excuse me. Let's take the patient to the ICU and watch him closely. And we'll get another Quantra while we're in the ICU. And once again, it's so easy that even in the middle of the night, I can call the ICU nurse will call me and say, hey, we're having a little more oozing or bleeding. And I'll say, okay, do a Quantra. And they walk right over to the operating room, which is where we keep our Quantra. And they'll fill that 3 millimeter blue top, put it in, and within 15 minutes, I'll get something on my phone with the entire picture. So here we are. We're in the intensive care unit. My chest tube is still dry. I do have that 2nd, or actually 3rd unit of platelets, but I'm not going to use it because there's no reason to use it. So I sent it back to the lab. And all this, I ordered 3 units of platelets. I transfused 2 without viscoelastic testing. Usually what us cardiac surgeons do, well, let's get cryo, let's get FFP, let's just give the whole kitchen sink to stop this. And once again, when you can look at the graphs, and you can see where you had been and where you are. So obviously I decided to go with a Quantra machine for viscoelastic testing. And I wanted to develop at least an algorithm such as that will allow me or anybody else on my team, any of the other cardiac surgeons, any of the nurses to understand not only the Quantra, but to know and treat patients with good coagulopathic accuracy rather than just throwing everything at them and hoping they're going to stop bleeding, so that I can tell when I have bleeding that's coagulopathic or when it's surgical and I need to go back. So this is the algorithm that I developed and we use on every single patient. We get a baseline Quantra, one on pump, one post-protamine. No matter what the Quantra says, and it's not often, but occasionally the Quantra will say, well, maybe you need something, but there's no bleeding, so so we don't treat. Nevertheless, if the Quantra, if there is bleeding, but the Quantra is normal, if I'm in the operating room, I'll look for further surgical bleeding. If I'm not, then I'll kind of have to decide, do I think this is surgical bleeding on other parameters? If so, then we return to the operating room. If not, then we'll get a Quantra in an hour. If it's still negative and there's bleeding, I'll go back to the operating room. Nevertheless, if there is bleeding and the Quantra is positive, at that point I would treat, and then the nurse or the other surgeons or the PA or whatever can follow this algorithm. I apologize for the small size, but if you'd like to have this or look at this, I could certainly give it to you. So I did about 60 patients without the algorithm until I developed the algorithm. Then I did 60 or so, 65 patients with the algorithm, because I wanted to see what is the effect of viscoelastic testing using this device, using an algorithm in a cardiac surgical program that is already well-versed in patient blood management. I wanted to make sure that viscoelastic testing was making a difference, even though we transfused very, very rarely. So we matched 64 patients in the pre-algorithm Quantra and pre-Quantra algorithm without the algorithm, with the algorithm, and then these are, like I said, this is all comers: CABG aortic valve replacement, mitral. We had a few aortic replacements, etc., and then looked at the utilization of blood and blood products. This is a little bit complicated with the p-values. Nevertheless, I'll show you the graphs. And here we have that, we made a little difference in packed red blood cells. Obviously, this is not significant. We've decreased our utilization of platelets and cryoprecipitate, and FFP is almost non-existent. We used 1 unit of FFP in those patients, 65 patients. And I think, especially without viscoelastic testing, with your surgeons, I bet you the first thing that we give when there's bleeding is FFP, because we'll get a little volume, a little FFP. But we've really found that there was very little need for fresh frozen plasma, more of a need for cryofibrinogen and platelets, but nevertheless still less than before. So, and then I just looked at the various costs of the various blood and blood products, and using the Quantra with the algorithm, we saved in about $40,000. I mean, it's not huge, but it's at least, to me, I'm treating the right process with the right treatment. So, patient blood management, though, is a comprehensive multimodality blood conservation program like I talked behind, but something more is needed. This is a Class 1 recommendation from the STS, and if you can't measure it, you can't improve it. So I just kind of, since this is talking about patient blood management, not just viscoelastic testing, I'd like to show you what we do at our hospital. We have a very capable PBM team, and we have 11 years of data. And this is hospital-wide. This is in cardiac surgery. After I proved to the hospital that we can do cardiac surgery requiring very, very little blood and blood product transfusions. The hospital wanted to go this hospital-wide. And this is the amount over 11 years that we had decreased use in packed cells, in fresh frozen plasma, and platelets are a little more difficult, especially as over the last 13 years, platelet inhibitors became ever so more popular. And this is per 1,000 patient days. And not only can we look at the total amount transfused, but the reason for transfusions. This is 2-unit orders, meaning when the physician orders 2 units without giving one and then rechecking to see if we need, and you can see significant improvement over the years. We look at total transfusions given when the hemoglobin is greater than 7 grams per deciliter. And once again, a decrease. Not only do we look at hospital-wide, but we look at it by department, and we even look at it by provider. And not only do we look at red cells, but we look at FFP utilization, and once again, we look at FFP utilization and what the actual reason for utilizing FFP and what the actual reason for utilizing platelets as well, and who gave the platelets. So it's a very in-depth kind of big brother looking over your shoulder whenever you use a unit of blood or blood products. So nevertheless, it's a good thing because obviously not only do patients get better treatment, they are not exposed to a liquid organ transfusion of blood, but it saves money and it saves untoward consequences of blood transfusions. If you look at from June 2012 to this year, applying activity-based cost savings, YRMC, which is not a big hospital, it's about 250 beds. We do about 250 hearts a year and about 100 structural hearts, so about 350 altogether. Nevertheless, we saved, but this is for the whole program, and we saved almost $10 million in red blood cells and $3.5 million in FFP. 71,000 in platelets. Once again, platelet inhibiting drugs are much more frequent, and I think that's why you haven't seen the changes that you've seen. And if I just have a couple of minutes, I want to talk to you about, I really enjoy talking about patient blood management to perfusionists. And the reason is that we all have relationships, especially in the operating room. Unfortunately, cardiac surgeons, I believe, have been somewhat slow in espousing patient blood management. And really, they're the only ones who can really do it right because they see the patients preoperatively, intraoperatively, and postoperatively. And patient blood management is just not only intraoperative. Nevertheless, the anesthesiologists and the perfusionists have really taken the helm with patient blood management. And we need you guys to continue patient blood management for our patients. So there are OR relationships, there are different OR relationships. So we have the relationship of the surgeon and the assistant, which is more like these two. We have the association between the surgery and the anesthesiologist, which is like Don Quixote and Pancho. And, you know, really the anesthesiologist is, they're not, but the surgeons oftentimes think that they're very subservient and anything that happens is their fault, the anesthesiologist's fault. But we have a special relationship with our perfusionists, pretty much because we really don't very much understand what your guys are doing back there other than keeping our patients alive while we do what we like to do on them. But we have a very high consideration, I believe, in most, and I think you all will agree to that. You guys are the ones that can really encourage surgeons who are not practicing patient blood management to practice it not only in the operating room, but preoperatively and intraoperatively. So I think with that, I'll quit, and I think we'll take any questions that you might have for Julie or myself. Thank you.
I think I'll start off. Dr. Tibi, thank you for an excellent presentation. I've been in the field like many of my other older brethren and sisters back there for some 30 years, and we've definitely seen a different approach to blood utilization in the ORs.